ladies and gentlemen, friends and colleagues. First of all, I'd like to thank High Sky Medical for the invitation to give this talk this evening. It's really a pleasure to be here. So over the next 25 minutes or so, I'll be addressing identifying patients with more severe MAFLD. So to set the stage, I would just like to spend a few minutes to talk about the old term NAFLD or non-alcoholic fatty liver disease. NAFLD encompasses a spectrum of liver condition that is characterized by excess accumulation of fat in the liver. In the majority of cases, is related to overnutrition and obesity. And for strict definition of NAFLD, significant alcohol consumption and other causes of chronic liver disease must be excluded. This is the spectrum of NAFLD. At one end is simple steatosis. And in patients with more severe form of the disease called non-alcoholic steatohepatitis or NASH, it is defined histologically by the presence of lobular inflammation and hepatocyte ballooning. Patients with NASH are more likely to develop fibrosis and cirrhosis. NASH patients, especially those with advanced fibrosis, are at increased risk of developing complications such as liver cancer and decompensation. However, across all this whole spectrum of patients with NAFLD, these patients are at increased risk of cardiovascular disease because of the close association of the condition with the metabolic syndrome, which is a constellation of risk factors for cardiovascular disease. In fact, cardiovascular disease is the leading cause of mortality in NAFLD patients. This slide shows you the natural history of NAFLD. Its annual incidence is about 3 to 4%. And 25% of patients with steatosis go on to develop NASH and have fibrosis progression in 3 years. And patients who have NASH, which is the more severe form of the disease, have fibrosis progression at a faster rate, at an average of 1 stage over 7 years, while patients with simple steatosis progress slower with fibrosis progression of 1 stage on an average of 14 years. In those patients who have developed cirrhosis, the risk of liver cancer is 1 to 4% per year. As you have heard from both Professor Huang and Dr. Dao earlier, fibrosis assessment is very important in patients with chronic liver disease. It is the same in patients with NAFLD as well. You can see in this study, patients who have significant fibrosis are at significantly greater risk of liver-related mortality during follow-up, nearly 10 times. And this risk increases as the severity of the fibrosis increases, so much so that patients with cirrhosis are over 40 times a higher risk of liver-related complications and mortality. Next, I'd like to move on to the fundamental issues of the older term NAFLD. As you have heard earlier, the diagnosis of NAFLD requires exclusion of significant alcohol intake and other causes of chronic liver disease. However, we know in reality that the same patient may have more than one cause of chronic liver disease. In fact, we do see patients who have got fatty liver due to obesity, who at the same time consume more than a modest amount of alcohol. We also see patients with chronic hepatitis B infection who has fatty liver that is related to obesity. The other issue is that the term NAFLD does not in any way attribute the disease to its underlying etiology. We know that the majority of cases of NAFLD are related to metabolic syndrome and obesity. Because of this fundamental issue, Eslam and colleagues have proposed a new term, which is metabolic dysfunction-associated fatty liver disease, or MAFLD. It is diagnosed in the presence of hepatic steatosis either by imaging, blood biomarker, or histology in somebody who is either overweight or obese, has type 2 diabetes mellitus, or has at least 2 metabolic risk abnormalities. The metabolic risk abnormalities includes the criteria for metabolic syndrome, and in addition to that, 2 other criteria, which is elevated HOMA-IR and elevated HSCRP level. The term MAFLD has been endorsed by the Asia-Pacific Association for the Study of Liver, as is reflected on this clinical practice guideline released last year. The term MAFLD has also been endorsed by the Malaysian Society of Gastroenterology and Hepatology. When we look at these 2 definitions, we can see that the majority of patients who fulfill the criteria of NAFLD would fulfill the criteria for MAFLD as well. However, there will be about 5 to 8% of patients who fulfill the criteria for NAFLD but do not fulfill the criteria for MAFLD. These are mainly patients who have got hepatic steatosis, but with a mild or no metabolic abnormalities. On the other end, we can see those patients who do not fulfill the criteria for NAFLD but fulfill the criteria for MAFLD. These are in fact patients who have hepatic steatosis as well as metabolic syndrome, but because they also have other causes of chronic liver disease such as significant alcohol consumption, hepatitis B infection, and so on, they do not fulfill the criteria for NAFLD. In order for us to understand the importance of today's, the topic of today's talk, which is identifying more severe MAFLD, I would like to refer to this study by Professor Vincent Wong from the Chinese University of Hong Kong. As you can see here, there's a very high prevalence of NAFLD in the general population. So in this population-based study, NAFLD diagnosed by magnetic resonance spectroscopy was seen in over a quarter of the general population. However, only a small but significant proportion of patients has advanced liver fibrosis. So how is it that we can actually identify patients with more advanced liver fibrosis, of which we know are at higher risk of liver-related complication and mortality, so that this patient can be linked to the necessary care? For that, I would like to show you a few slides. One is this particular study on over 1,000 NAFLD patients who had liver biopsy across multiple centers in Asia, whereby the main indication for liver biopsy was persistently elevated liver enzymes, and 63% had NASH, 17% had advanced fibrosis, and the risk factors for NASH and advanced fibrosis, you can see here in this box. The risk factor for NASH include elevated BMI, diabetes, dyslipidemia, elevated ALT, and elevated AST, while the risk factor for advanced liver fibrosis include age more than 55 years old, diabetes, and platelet count. What you can see here is diabetes is a risk factor for NASH. Diabetes is a risk factor for advanced fibrosis. And that shows us that diabetes is actually a very important factor to consider to identify patients with more severe NAFLD. And we also performed a study using transient elastography in patients attending the diabetes clinic in our hospital. You can see there's very high prevalence of NAFLD in patients with diabetes. Over 70% had NAFLD. And based on a liver stiffness measurement, about 1/5 of these patients actually had advanced liver fibrosis. And among those patients who had liver stiffness measurement more than 8 kilopascal, who were referred to the gastroenterology and hepatology clinic for further assessment, of which some of them had liver biopsy, you can see that the majority of them had NASH, and the majority of them had some degree of liver fibrosis. And you can see that more than 1/3 of these patients had histological confirmed advanced liver fibrosis. These two slides tells us that patients with type 2 diabetes represents an important target group to identify more severe MAFLD. And it is important for us to have a clear assessment and referral pathway. And this is also the reason why in the clinical practice guideline for management of type 2 diabetes mellitus here in Malaysia, the latest edition, which was released end of last year, has for the first time has a section on NAFLD. The rationale behind this is because there is already in existence a system in the diabetes clinic whereby patients are assessed for target organ damage. For example, diabetic retinopathy, diabetic nephropathy, peripheral nephropathy, peripheral vascular disease, and so on. So it makes sense to actually co-localize the assessment of severity of liver disease in the diabetes clinic. We do not need to reinvent the wheel. The system is already there, but what we really need to do is to create the awareness and to include the assessment of liver disease among diabetes patients, of which you have already heard earlier, are at increased risk of more severe NAFLD. The inclusion of NAFLD in the clinical practice guideline for type 2 diabetes, in fact, has been cited as a potential strategy in this white paper by the Economic Intelligence Unit and the ESO International Liver Foundation, which was released earlier this year. I've mentioned about the NAFLD section in the clinical practice guideline for type 2 diabetes mellitus. I would like to use this case study to illustrate to you some of the important points in this NAFLD section of the type 2 diabetes guideline. This is a 67-year-old man who has diabetes and dyslipidemia. His medications were metformin 850 milligram twice daily and simvastatin 20 milligram at night. You can see that he's slightly obese, but if you use the Western cutoff, he will be overweight. BMI of 25. His blood pressure, his glycemic control, and his lipid profile are all within acceptable range. So this is a typical patient that you will see in primary care or maybe in the diabetes clinic, and they will just be continuing on medication and continue on follow-up because the metabolic risk abnormalities appear well controlled. Okay, so let me just show you one section of the type 2 diabetes guideline, the NAFLD section, whereby the recommendation is to have simple blood tests like a full blood count and liver function test as assessment of the liver for patients with type 2 diabetes. So first of all, we look at the liver function test. Those patients who have normal ALT and AST, they can have this repeated annually. Whereas those who have elevated ALT and AST, they should have an ultrasound to diagnose fatty liver and to exclude a focal liver lesion. Other common causes of hepatitis should be excluded as well. This would include chronic hepatitis B infection, chronic hepatitis C infection, alcohol, as well as drug-induced liver injury. And after we have established that the reason for the elevated liver enzyme is due to fatty liver, the patient should be advised on lifestyle modification. I'll share some data on lifestyle modification for management of fatty liver later in the talk. And following that, the patient can have repeat ALT and AST after 3 to 6 months. In those patients who have persistently elevated ALT and AST, or in those patients where other less common causes of hepatitis is suspected, you may consider referring the patient to a gastroenterologist and hepatologist. And you have heard from Dr. Dao in her talk earlier that the fibrosis 4 score is a very useful tool that can help you assess the patients for liver fibrosis. And as mentioned by Dr. Dao, you will need the age, ALT, AST, as well as the platelet count. Those patients who have got a fibrosis 4 index of less than 1.3 are very unlikely to have advanced liver fibrosis, and this can be repeated every 2 to 3 years. However, those patients who have got a fibrosis 4 index of more than 1.3, they may have advanced liver fibrosis and should be referred for liver stiffness measurement and should be considered for referral to a gastroenterologist or hepatologist for further assessment. So we'll go back to the case that you have seen earlier. Because of the NAFLD section in the type 2 diabetes guideline, the attending doctor has has asked further question to the patient and found that the patient's father died of cirrhosis and possibly liver cancer. And the attending doctor also sent a full blood count and liver function test, simple test, which can be used to assess the liver in these patients whom we know are at increased risk of more severe NAFLD. So lo and behold, the patient has a low platelet count and elevated AST and GGT level. And when we use the online calculator for the fibrosis 4 index, we just key in the age, AST, platelet count, and ALT. We found that the fibrosis 4 score was 3.64. This is more than the lower cutoff of 1.3, which suggests that the patient may have advanced liver fibrosis. In fact, it is higher than the upper cutoff of 2.67, which makes advanced fibrosis very likely. So this patient had subsequently had an ultrasound, which would not have been ordered if not for the full blood count and the liver function test indicating a red flag. So the ultrasound did show that the patient has cirrhosis with splenomegaly. However, there was no focal lesion. And on further questioning, the patient did not have any significant alcohol intake. The patient was referred to the gastroenterologist and hepatologist who did some further tests to exclude other causes of cirrhosis. And at this point in time, I would like to remind that in fatty liver disease, the ultrasound may only show fatty liver, even when the liver is cirrhotic. This is why the fibrosis 4 index is important to evaluate fibrosis in this patient. And those who have got increased fibrosis 4 index of more than 1.3 should have a liver stiffness measurement. I'll move on to another section of the guideline, which talks about liver stiffness measurement. So those patients who have got liver stiffness measurement of less than 10 are unlikely to have advanced liver fibrosis. So based on a study that was done not too long ago, the negative predictive value for liver stiffness measurement less than 10 to exclude advanced fibrosis is in the range of 93 to 96%. Those patients who have got liver stiffness measurement of 10 to 15 may have advanced liver fibrosis. They require monitoring, for example, repeating in 1 year, or consider referral to gastroenterologist or hepatologist. In those patients who have got liver stiffness measurement more than 15 kilopascal, they are likely to have advanced liver fibrosis. They should be considered for liver cancer surveillance and should be considered for referral to gastroenterologist and hepatologist. Whereas those who have got liver stiffness measurement more than 20 to 25 kilopascal, especially in the presence of thrombocytopenia, are likely to have clinically significant portal hypertension. This patient should be referred to the gastroenterologist or hepatologist and should be considered for liver cancer surveillance, as well as varicose screening. The cutoff that should be used to consider for referral to gastroenterologist and hepatologist really depends on the availability of this expertise in the locality. And just to mention that liver stiffness measurement more than 15 kilopascal has a positive predictive value for cirrhosis of between 86 to 92%. So let's go back to the patient that we discussed earlier. He had transient elastography, which show attenuation parameter of 322, which is consistent with severe steatosis. He also has got a liver stiffness measurement of 27 kilopascal, which is suggestive of clinically significant portal hypertension. And just a reminder to look at the IQR over median, of which less than 30% would be considered a reliable transient elastography examination. So because of the high liver stiffness measurement and the low platelet, the patient underwent a gastroscopy for varicose screening. And as you can see here, he had large esophageal varices with red markings, as well as portal hypertensive gastropathy. He underwent endoscopic varicose ligation and was started on propranolol 10 milligram twice daily. In terms of management, the patient was given advice on lifestyle modification. His metformin was reduced to 500 milligram twice daily, and he was started on Empagliflozin 12.5 milligram daily, which is a SGLT2 inhibitor or sodium glucose cotransporter 2 inhibitor. I'd like to talk a bit about these few management steps. We'll just first look at the lifestyle intervention in NAFLD. This is a very well-cited study on almost 300 NAFLD patients who had liver biopsy confirming a NASH. They were enrolled in a comprehensive lifestyle program for a year, and they had repeat liver biopsy at the end of the study. And you can see here, as the amount of weight loss increases from less than 5% to 5 to 7% to 7 to 10% to more than 10%, the proportion of patients who had resolution of NASH increases from 10% up to 90% in those who have at least 10% of total body weight loss. And you can see that 40%, 45% of those patients who have at least 10% body weight loss had fibrosis improvement. This shows us that lifestyle intervention leading to weight loss can result in a remarkable improvement in patients with NAFLD. I would like to show you another study, which was a randomized control trial, including 154 patients with NAFLD who were identified during a population screening. They were randomized to either a dietitian-led lifestyle program or usual care for 1 year as well. And the primary outcome was a remission of NAFLD as evidenced by hepatic triglyceride content of less than 5% based on MR spectroscopy. Again, you can see as the total body weight loss increases, the proportion of patients who achieve remission of NAFLD increases from 13% among those who lost less than 3% body weight to as high as 97% among those who have lost at least 10% of their total body weight. And more importantly, when the results was stratified based on whether patient was obese or not, you can see a similar pattern. This essentially tells us that even among non-obese patients, if they have NAFLD and if they can go on a lifestyle change, achieving weight loss, they can also achieve the improvement that we see among obese patients. Next, I would like to talk a bit about SGLT2 inhibitor. This is a pilot study that we did using Empagliflozin for biopsy-proven NASH. It was a small single-arm open-label study where we enrolled 9 patients who were treated with Empagliflozin for 24 weeks, and they had a repeat liver biopsy at the end of the study. As expected, we saw improvement in various metabolic profile. Patient has significant reduction in their BMI, waist circumference, blood pressure, fasting glucose, as well as total cholesterol. But in addition to that, there has significant decline in their serum GGT level. There has significant decline in their volumetric liver fat fraction as measured by MRI. They also had a significant decrease in steatosis grade, ballooning grade, as well as fibrosis stage. And when we compared the result with a historical placebo of a randomized control trial that we have done previously, these improvement in steatosis, hepatocyte ballooning, as well as fibrosis remain significant. Well, this is just a single arm open label study. Do we have any results of randomized control trial? In fact, we do, but it's not a histological endpoint. Rather, it was based on MRI. This a study on patient with diabetes and NAFLD who was randomized to either Empagliflozin or placebo. They had MRI PDFF at the beginning as well as after 20 weeks. And as you can see here, those patients who received Empagliflozin had significant reduction in the percentage of fat in the liver. This was not seen in the placebo group, and the difference remains significant when compared between the two groups. So back to our case, the patient had the propranolol optimized and subsequently had a repeat gastroscopy. And as you can see here, only small varices and scar was left. And 1.5 years later, during follow-up, his weight reduced from 77 kg to 65 kg. This is from his lifestyle modification as well as from the SGLT2 inhibitor. And he has a total body weight loss of 15.6%. And you can see that his metabolic profile improved across the board, from the glycemic profile to the lipid profile, and even his liver enzymes normalized. And he continued to be on liver cancer surveillance with a 6-monthly ultrasound and alpha-fetoprotein level. He subsequently had a repeat transient elastography after 2 years, and you can see that his attenuation parameter improved. His liver stiffness measurement improved as well. So, ladies and gentlemen, I would like to conclude by saying that MAFLD is the liver manifestation of the metabolic syndrome. It is highly prevalent among patients with type 2 diabetes, and patients with type 2 diabetes are more likely to have more severe MAFLD. It is important that there's a clear assessment and referral pathway so that patients with more severe MAFLD can be linked to gastroenterologist and hepatologist care, while patients with less severe MAFLD can remain in primary care or endocrinology where they are best managed. Thank you very much, and I'll be happy to take any question.
Thank you, Dr. Chan. And tonight we have the 3 very wonderful talk about the various kind of topics in NAFLD. And here I have some questions for Dr. Tao and Professor Zhang. And as for Dr. Tao's speak, and some of our